on digital diabetology, a tale of apps, clouds, and gadgets, a care, by Dr. A.G. Unnikrishnan. Dr. A.G. Unnikrishnan is actually God's gift to Pune from the country of God. Thank you. Yeah.
Thank you, Dr. Gandhi, for that very generous remark. It's a pleasure to have you to chair this session, and Dr. Archana Sada and Dr. Purohit. We have chosen people with a strong interest in technology because they will not just chair the session but take it forward and lead the question answers and make it very interactive. And thank you for that. And I'm going to talk about some practical aspects. I will not talk. Thank you, first of all, for being here in good numbers. And I'm just going to discuss some cases where the use of technology can help. So my first case is how technology can be used to innovate self-monitoring of blood glucose. So this is a case. Now, we know that in many parts of the world, people still use a diary like this, where the patient records his or her blood sugars and sometimes misses the recording and doesn't record it every day. Whereas we all know that recording should be done regularly. So this is one of my patients with pregnancy-related diabetes. And you can see her records. It's very difficult for either the doctor or the patient to make sense of this kind of a record, clinical record. And therefore, this is a lady who was admitted at the Chalaram Hospital, a 28-year-old pregnant lady. She is on basal insulin, Detimir. As you know, in pregnancy, we give Detimir and metformin. And she was hospitalized for glucose control because she was pregnant and we needed to control sugars very quickly, very well. And she was put on Detimir and rapid-acting insulin. But that's not the point of this presentation. When she was admitted, her fasting was 149. It came down to 81. The post-breakfast was 194. It came down to 148 in general. But what we did is we put her on a glucometer which syncs to a smartphone and to a cloud so that the patient knows. So this is a system. This is again not to promote any particular brand, but this is just to promote that lots of glucometers now are connected to the cloud. So you have a glucometer connected to a smartphone, connected to a cloud, and the patient can actually see the reports online. And this is the web page in our hospital where our diabetes educator looks at the system. And this is what happened to this patient. So, here you can see the time of the day and the pattern. The patient checks, pregnant patients check 6 times a day. And you can see 2 times the blood sugar is going up here and here, that is after breakfast and after dinner. But this is the macro picture. This gives you on each day what are the blood sugar levels. So the upper panel tells you on each day how the sugar levels are, and the lower panel tells you at what time of the day that sugar is highest. So what we found is that our diabetes educator looked at the system and found that her sugars were going up on particular day, and we called her on phone. And then the diabetes educator found that the patient had asthma and she had stress, and that stress caused the blood glucose levels to rise, and we increased the rapid-acting insulin with breakfast and dinner. And that was done on email by the diabetes educator. And then, the blood sugars settled by the 17th of September, the blood sugars came down to normal. So this is just an example of how technology can actually be used to innovate the glucometer experience. Now let's look at how the insulin titration can become a very easy process as compared to before. Now this is a second case, a 57-year-old lady. She's had bariatric surgery, mini gastric bypass, and she's been diabetic for 25 years. Now she was on glimepiride, vildagliptin before surgery, and she continued to be on vildagliptin and glimepiride. Insulin was stopped because you can see after bariatric surgery, her weight came down from 86 to 70. BMI came down from 37 to 30. HbA1c came down quickly from 12 to 9. But not everybody with bariatric surgery gets better. Actually, she went to some other state, got the bariatric surgery done, and came back. And despite the surgery, her fasting was high, 158, postprandial is 248. I'm not here to discuss bariatric surgery, but I'm just here to discuss that now patient cannot now tolerate metformin, is on glimepiride and vildagliptin. Fasting is higher, you need to add basal insulin. But the patient, of course, she doesn't tolerate SGLT2 or metformin, and she's worried about hypoglycemia. So how can you send this patient home with, say, 10 units insulin if she's worried about hypoglycemia, but at the same time, she would like to monitor at home? So now there are lots of apps and devices which drive these kind of dosing. You have an app called ISAGE, ISAGE, which supports this sort of a titration at home. And these apps work how the doctor plans an algorithm. This tells the patient what dose to take. For example, the doctor starts with, say, 20 units, tells the patient to check the blood sugar at 7 a.m. dose, and gives the time of insulin. For example, if it is basal insulin, at 10 p.m., patient has to take the insulin, check the sugar at 7 a.m., and say 20 units have to be given. And the app will tell, once the patient enters the blood glucose level, the app will tell how much insulin to take. I see a lot of you taking photographs, but please don't take photographs. You can take photographs if you wish, but by July, all these slides will be loaded as presentations in our e-learning platform and will be available for free. So our e-learning platform is free for anybody to access and see these videos after a few months. Even last year's conference, which had a strong digital technology, videos are already available. So please log into our e-learning platform and access last year's entire conference, and few months we'll have this also ready. So please don't worry. It's not like taking notes in a class, because you will have everything with you on your fingertips free of course. So this is how the system works. This is one of those apps, My Dose Coach apps. There are several other apps as well. So patient enters the blood sugar report. Already the doctor has put a schedule. If fasting is 80 to 110, give this much, continue the same dose, 110 to 130, increase insulin by 2 units, etc., etc. And this patient, this is of course a US FDA Class 2 device, and it is available now in India. And we've given a very simple algorithm. For example, 90 to 120, continue insulin. So you can choose your algorithm. It need not be the algorithm recommended by the ADA or some other association. You can choose your algorithm, and then the patient titrates according to that. For example, if it's an elderly lady sitting at home, prone to hypoglycemia, you want to keep the fasting 80 to 130, that's fine. Now this patient, as you can see, this shows. You can also sit in your clinic and see how the patient is titrating and how the sugars are going on. And you can see this lady did not even have to change the 10 units. 10 units worked very well. But the patient had the comfort of knowing that, yes, there is an algorithm, I'm following it, and my doctor has also suggested that algorithm. This is not artificial intelligence based. The app does not decide. You put in the algorithm. Similarly, I had another patient, a 64-year-old gentleman. So you can see on 1st September, his blood sugar fasting was 238, and he was on this, and from 14 he increased to 16, increased to 18, and by 20th September. So the patient can do this at home. Otherwise, usually you call the patient after 5 days, 6 days, or on phone, keep on adjusting the dose. This the patient can do it at home, but of course this is only for some sort of tech-savvy patients or their relatives. Now the third case I want to show you is how glucose profiles can be translated into regimen changes. So how can we change? Does technology change the regimen? This is again one of my patients. He is a 64-year-old gentleman, hypertensive, diabetic, has ischemic heart disease, neuropathy, retinopathy. In fact, he came to see me just 2 days back, and he's doing quite well. He has been on a continuous glucose monitoring system called Dexcom, which is available in India but very costly, so very few people use it. Dexcom, the advantage is you can see the results on your watch, on your phone. Continuously there is a small device. So it's like a CGM. It's a proper CGM which is real time and you can see it, and these are his reports. He's on regular insulin and degludec insulin. So 3 shots of regular insulin and degludec insulin. And what you can see, each color is for each time of the day. And you can see that the breakfast time, the sugars are pretty okay. So the degludec is working. After lunch, there is quite a bit of variation. After dinner, quite a bit of variation. I'm not showing any complex calculation. I'm not sure if I know it either. But I just want to say that his HbA1c was high, post-meal spikes were noted, regular insulin we stopped and we added Lispro. So you can see what happens now. Degludec regular insulin was changed now. So this is a Dexcom device, small reader and transmitter. And this device, you can patient can anytime look at the sugar, see it going up, down, measure it, etc., etc. As I said, the idea is not to show a device or B device. Idea is to show how the technology is available today to understand therapy. So you can see this is the initial one, degludec and regular insulin. When we change to degludec and Lispro, you can see the post-meal spikes were improved and the HbA1c improved, but you can see there was some tendency to hypoglycemia. The yellow mountains are hyperglycemia and the pink valleys are actually hypoglycemias. You see some hypoglycemias appearing. Now, can't you do this without CGM? You can do it without CGM, but you will not be able to really find out whether your treatment has actually made a difference because patient has to otherwise check everything at home, and this makes it so easy to see that. So I'm sure you're all bored of seeing all these cases, so I'm showing one case which is really not evidence-based, and I apologize for that case. This is a 45-year-old gentleman. Again, as you see, the Dexcom can be worn on the watch or on the phone, and you know, he's 45 years, his HbA1c is 5.4%, and he has normal fasting and PP. His levels are pretty well controlled. And you can see this, again, the Dexcom pattern of a normal person. You know, the sugars are so tightly controlled in normal people without diabetes. And each time, you know, he has food, it comes down to normal every day. But you will see there was a small spike here at midnight happening. And this happened because he was watching an IPL match, and that released cortisol because of the stress of watching a cricket match at night. This is not his photo. He watched a cricket match at night, opened the refrigerator, he ate a pastry, he ate a rasgulla, and he didn't eat the rasgulla, he ate the rasgulla and the liquid of the rasgulla. How do I know that? Because this is my CGM, it's my recording, I've done it on myself just to see what happens. If you've noticed the name, my name is there, Dr. Unnikrishnan. So it's my reading, you know. So just to give you an idea that even people with a normal HbA1c. So I was 45 years then. Now I'm almost going to be 49 this year. So certainly this is not me. So this is just to show that, you know, the science behind the midnight snack. You get up at night, open the fridge, eat food. We all do that, even I do that. And even in a non-diabetic person like me, you can have a little spike of about 140, 150 out there. So that's what it causes, eating at different times, because it's like the brain is like the circadian clock is thinking it's time to sleep, whereas the liver clock is saying you have just eaten food and it's daytime, and the brain is telling no, it's night, you have to go to sleep. The melatonin is telling you it's night, and the liver is telling you, the liver's biological clock is telling you it's daytime. So it's confused, and this is not good for the body. Sorry, I too have to learn from that. On that point, now I'm going to show you the fourth case, how digital diabetology can help you to understand a disease. How a disease, you can understand it better using digital diabetology. And this is a 70-year-old gentleman, and this is a case compiled by Dr. Rajesh, who used to work with us, and he's on maintenance hemodialysis, and he's doing regular hemodialysis in a small, far-off center. But in that dialysis center in a remote area, he developed hypoglycemia. But interestingly, before he was put on this, before he developed hypoglycemia, he was by luck already wearing a CGM device. He was wearing an AGP flash lipopro device before. Unfortunately for him, but we could understand what happened to him. So he was shifted to Chalaram Hospital's ICU. We found that he was wearing this. So we could know exactly what happened to his sugars during dialysis. So clinically, his BP pulse was unrecordable. His blood sugar was 22. We initiated CPR and we gave him dextrose. He had ventricular tachycardia. He was on again the CGM device. And just to see that on that, you know, he had hypoglycemia and then he had hyperglycemia. And you can see that during dialysis, there was hypoglycemia and hyperglycemia. Just to show you, this is that during dialysis, there is hypoglycemia, and post-dialysis, there is hyperglycemia, and this can be understood better using AGP. Not that we should put any dialysis patient on CGM, no. But yes, we can find out what happens to these patients using CGM, and many of the patients with dialysis skip their insulin in the morning of dialysis. They take extra meal, but we found that even then they can have hypoglycemia, and Dr. Rajesh has published that paper. So I'm coming to my last case. I don't want doctors to think that I'm a very tech-savvy diabetologist. These are all few rare cases where I've used technology. Most of my patients still use the ordinary diary, write in their logbook. I prescribe some metformin, some sulfonylurea, and I manage the patients in a cost-effective manner. I don't put this on every. So I thought I will show some rare cases for the benefit of the audience, and we have a tendency to show our successful cases. So I apologize if my cases are all looking good and successful. We have a tendency to show that, and I too show that these are some of the successful cases. This is a very interesting gentleman. He's a so-called type 2 diabetic for 23 years and he's an amputee. So he came to my clinic initially and he had 2 to 3 hypoglycemias per month. And you see, he was on a mixed insulin, gliclazide, metformin, vildagliptin, and his sugars were so high on that. And because he was an amputee, he was not an amputee because of diabetes. He was actually a sportsman and he had an accident and he was an amputee. And because of that, he could not exercise. And his body had by then begun behaving like a proper type 1 diabetic. He was insulin, he did not have any insulin in his body. And you can see that I had to put him on basal bolus insulin. And initially, even on basal bolus insulin, I could not control his sugars, and he was quite a well-off person. He could afford these kind of treatments. So I put him on the pump. So we put him on what is called a 640G pump, which is available in India, which was, now we have the advanced one available in India. It is called the artificial pancreas, but it's not really an artificial pancreas. And this particular pump model that he was on has got something called a predictive suspend technology, where the threshold suspend pumps go down, and then when the sugars fall below a particular level, it increases. But this predictive suspend pump predicts that the blood sugar is going down, and before it goes down, it goes up. So this is the only patient I have on this pump. So I don't have too many patients on this pump, so I don't know much about it. But I know that he was on the pump and he was doing very well. And this is the pump, and it measures the glucose levels, and he was doing that. Now, this is again not to talk about the pump and what the pump does. This is again to focus on the technology. But the problem with this pump was that he had put on weight, quite a bit of weight on the pump, because he could not walk. He was an amputee. He was actually a sportsman, so he was doing upper body exercises on a wheelchair and usually doing a lot of weightlifting and all on the wheelchair. He was a strong man. But still he was putting on weight, and he asked me, what should we do now? Because I am on insulin pump, doctor. I am on metformin, I am on vildagliptin, and now what can I do? So he was behaving more or less like a type 1 diabetic, but because of the weight, I put him on a GLP-1 receptor agonist. I put him on liraglutide. So with liraglutide, this is when he came to my clinic after that. He looks much more thinner. This is in my own cabin. He's much more thinner now. His blood sugar levels, before you can see they were fluctuating, and now they are much better. So he's on CGM with a insulin pump, and he's on a GLP-1 therapy. So as I said, this is not my routine patient. These are all very rare patients. And you can see that he had hyperglycemic spikes initially, many in number. They have really come down, and he lost weight, and he also lost 9 kgs. And his insulin dose came down from from 100 to about 69 units, and HbA1c also came down from 8, something like 8 plus to around 7%. And I last saw him around in July 2018, and this was his reading. He was doing pretty well. Not perfect, but this is the closest that we have to this. So I have showed you 5 cases how technology can improve the glucometer experience, how technology can improve insulin titration, how technology can make treatment changes, how it can understand illness. I showed you a dialysis case where there is hypoglycemia and it got detected. It was important for us to understand that. And then I showed you how technology with the proper medicine could be used to achieve good control. So I've just scratched the surface of technology. Like Robert Frost said, the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep and miles to go before I sleep. Because there are lots of things in technology that I think this symposium will cover, because I've just looked at the surface, given you a glimpse, so that you can, in the next 2 to 3 hours, each of these will be discussed in detail, so that you will understand the importance of what is going to happen. Lots of interesting things here to understand is the Internet of Things, where Internet of Things is going to be everywhere, and you'll have to have wearables and smartphones. Remote trials which are done by technology without the patient. Patient is somewhere far off, but the trials are done remotely. There has been at least one trial completed in diabetes recently on this. Social media, there was a study of type 1 diabetes and a low-calorie diet completely carried out, identifying patients with type 1 diabetes from social media. Point-of-care devices where HbA1c, lipid profile, we've also used it in our outreach program, done point-of-care. The bionic pancreas, where insulin and glucagon come into play. artificial intelligence and precision diabetes. You are going to hear Dr. Leaf Group talking in the next hall about precision diabetology and precision diabetes care, where you can come out with a personalized treatment algorithm for a particular patient, and that will suit, because diabetes, though we know diabetes of 4 types, diabetes may be of 5 clinical types, and 2 of those types may not be that aggressive in terms of complications as the other 3. So you can focus on those 3. You can also choose medicines which benefit those 3 diabetes, because some of them are associated with kidney disease but have more insulin resistance, and so you can choose which therapy. It's a rapidly evolving field. And also some ethical questions about these data points as to who owns this sort of internet-based data. Is it the patient who owns it? Is it the doctor who owns it? Is it the company that hosts the platform owning it? Is it the hospital that owns it or the clinic that owns it? To my mind, the answer is pretty clear. At the end of the day, all this data has to be owned by the patient. It is the patient's data. The patient has to give permission, and the patient should be able to voluntarily withdraw any data from the internet at any point of time without giving any reason. Because today, in today's world, whoever controls the data controls the world. And because data is the new oil. So these are all some of the ethical questions coming up. And I think, as I said, I've just shown you 5 cases, but the learned speakers after me will cover the other cases. Ladies and gentlemen, it's a pleasure talking to you. Thank you.